Good evening to you all, and this is the first time I'm making the video. Actually, I made earlier many videos on the PGTs, but I have, though I teach in the for the PDT in hematology and medical oncology, so I have just not made any such video. So today, just I want to make video for the PDTs who are in the hematology, who are doing. Who are actually doing DM in clinical hematology. So actually, some of the conceptual chapters, just I want to discuss like ALL or hairy cell leukemia or like DLBCL or Hodgkin's, non-Hodgkin's, etc. So my basic purpose will be to discuss the questions arbitrarily, because arbitrarily momentarily I will be discussing you the questions, and it will be a type of it is a though I am in concern with the university question, but I will be talking about the MCQ type question, and from there the MCQ type questions, the long answer can be easily be prepared and made out of that. So I am starting question with uh, because in hematology, particularly the malignancy and non-malignancy part is there. But first, I am starting with the non-malignancy on the malignancy part, and starting with the first question. Uh, First, you listen the question and you think for a while, and then I will be giving you the answer with explanation. This will be my the way of presentation in the video, and just uh, uh, you think, and then I will give you at least 2 to 3 seconds, and then I will be giving you the answer. Now, a patient has now a patient is presented to you with blast with immunophenotype CD13 plus membrane CD13 plus membrane CD19 plus CD79 plus and cytoplasmic CD22 plus. CD19 is negative. Uh, just a second. Sorry, CD10 is negative, CD19 was positive, and CD20 is also negative. Now, what is the most likely diagnosis on the basis of the question which I gave you? Just you think for a while. I am repeating the question once again. A patient had blast with the immunophenotype CD13 positive, membrane CD19, CD79A plus, and cytoplasmic CD22 plus, and but the CD10 was negative and CD20 was also negative. Now, what should be the most likely diagnosis that you could think of? So you just think for at least you take at least 5 seconds to 10 seconds, and then I will be giving you the answer with explanation. Now, just I am repeating the question again, and then I will be telling you the answer. Now, a patient had blast with immunophenotype CD13 plus, membrane CD19 plus, CD79A plus, and cytoplasmic CD22 plus, CD10 minus, and CD20 minus. So what will be the most likely diagnosis? Now actually the most likely diagnosis here will be early precursor BCL acute lymphoblastic leukemia. The reason for this is because here the antigen associated with the various stages of differentiation in ALL are early precursor B, that is pro-B-ALL, membrane CD19 plus, CD79A plus, and cytoplasmic 22 plus, and with common acute lymphoblastic leukemia like CD10 plus, and the late pre-B-ALL like CD20 plus. So cytoplasmic, just a minute, cytoplasmic mu heavy chain expression in earlier studies causes of B cell, we have already seen that in the early cases of the B cell precursor ALL will subdivided into those which were CD10 positive, so called as common ALL, and those with the CD10 negative for pre-B and pro-B or CD10 negative, B cell precursor. So co-expression of myeloid antigens is seen in up to 30% of the case, and most commonly CD13 like 14%, or CD33 14% or 16%. The presence of myeloid antigens in ALL does not have any effect on the treatment but can be useful in the immunological monitoring of the patient for minimal residual leukemia, as in the presence of these aberrant markers is treated in the patient signifies the residual disease. So it will be a case of the early precursor B cell lymphoma, because it cannot be a because by the markers you can say that it is the case of the early precursor B cell ALL. It cannot be a common ALL, as because here for the common ALL the CD10 should be positive, but here the question which just I have told, here CD10 is negative, so that is ruled out. Late precursor BALL also will not be the answer. The reason for that, CD20 is positive here, but in the question the CD20 is negative here. So these are the some of these are the option which you can exclude by knowing the ISC markers, immunohistochemistry. So in this way you can arrive at the conclusion that which one which could which could be the most likely answer. Now I'm asking you the second question. Now, a 33-year-old male which presents in the hematology OPD with the fever and the neck swelling for 2 months. Now, you listen the question carefully. This is also a very important question, and it generally these questions are asked either in the long run questions or in the long answer question or as a viva also. So I am discussing with this dual type of question. So a 23-year-old male presented with the fever and neck stiffness for 2 months, and the CT scan of the chest showed the anterior mediastinal mass, and the LDH was very high, that is 1600 units per liter, and the bone marrow aspirate shows 90% blast. Now, what should be the next step you should take on? I am repeating the question once again. A 33-year-old male presented with the fever and neck swelling for 2 months, and the CT scan of the chest were observed, and it showed an anterior mediastinal mass. Okay, and the LDH was very high. It was around 1600 units per liter, and the bone marrow aspirate and the bone marrow biopsy rather shows it showed the 90% blast. And what should be the next step? So just you take about 9 to 10 seconds, and then I will tell you the answer with explanation. Just a second. Now I think I have given you 10-15 seconds. So I am repeating the question. That is 33-year-old male presented with the hematology OPD with fever and neck swelling for the next 2 months. So the CT scan showed an anterior mediastinal mass and the LDH was very high, around 1600, and the bone marrow aspirate shows the 90% blast. So what would be the next step? So actually it is the case of, as per the WHO classification, it is the case of the hematological myeloid neoplasm and acute leukemias, and it identifies that it is one type of B cell ALL, termed as B cell lymphoplastic leukemia, and with the translocation that is 11q23. Now 11q23 translocation, that is, are always recurring cytogenic abnormalities in both AML and ALL. So that is the main thing you have to understand. The translocations are very important to understand, to differentiate between and the treatment regimes also. So you should understand this, and involving the same gene. And ALL for ML, the prognosis with ALL with 11q23 abnormalities particularly very dismal, particularly in the pediatric age group. And allogenic transplantation with hematopoietic stem cell from a HLA matched related donor does not seem to improve with the clinical outcome in the patient with translocation 4:11 positive leukemia. So it is actually the case of the actually it is a case of acute lymphoblastic leukemia, where you have to do the biopsy of the mediastinal mass to rule out any other cause, and you have to do a whole body PET CT also. And the best regime to start here would be the CHOP regime. CHOP regime would be the best chemotherapy to start immediately, so that the mass could be squeezed off and the LDH could be go down. And we should also wait for the biopsy report, so that any alternative differential diagnosis should not occur. So it is a case of ALL, and different types of ALL. The translocation, you have to understand that which translocation prognosis is, what is the translocation of which which type of prognosis. So this is also very important to know. Now Okay, now I am coming to the third question. This question is actually easy, but this question is also require very much concept. It is Blinatumomab is a monoclonal antibody and it target against what? So you have to tell me, and you have to tell rather yourself that Blinatumomab is a monoclonal antibody and it target against what? It targets against CD3 or CD19 or CD3 or CD20 or 22, CD4, CD79, etc. So you think for a while, and it is an monoclonal antibody, and it targets against which of the following the cluster differentiation. Just you think for a 5 to 10, you take around 2 to 3 3 to 5 seconds, and then I will be giving you the answer with explanation. Now, bilatonumab is actually a bispecific monoclonal antibody, and actually it enables the CD3 positive T cells to recognize and eliminate the CD19 positive ALL blast. So this is the main target that this monoclonal antibody does. And now when actually the bilantrumab when it concurrently binds to the CD3 and CD18, the T cells activated and directed to CD19 expressing target B cells, resulting as a cytotoxic T cell response. So treatment with bilantrumab results in significantly longer survival and overall survival than chemotherapy, resulting in adult patients with a relapsed or it is refractory with the B cell precursor ALL. So the precursor B cell precursor ALL, the bilantrumab works a wonder, and it should be tried because it targets overall the CD9, CD3 and CD19. Yeah. Now, now, this is also a very important question. It is quite sometime asked in university exam, in different university exams. A patient presents with in OPD, in hematological OPD, with the abdominal lymphadenopathy with peripheral blood lymphocytosis, and the immunophenotype which has been seen is CD22 plus, CD5 plus, and CD23 minus. And cytogenic abnormality analysis, it shows that shows that translocation 11:14. So, what should be its diagnosis? It's a bit easy question. Just you concentrate that what is being the patient is presented with. I am repeating the question once again. Patient presents with the abdominal lymphadenopathy and presented and peripheral blood lymphocytosis, and the immunophenotype is CD22 plus, CD5 plus, and CD23 minus, and cytogenic analysis shows a translocation 11:14. So what should be the diagnosis of this? I'm giving you 5 to 10 seconds. You think for the answer. What should be the correct answer for this? I think it is easy. I think you can all do this question because it is an easy question, and it was asked as a viva in one of the exam, in one of the university exam. Now, I think the time is you have thought for the answer. So, this type of present actually the provisional diagnosis is the mantle cell lymphoma. Okay, it is a type of the non-Hodgkin's lymphoma, and the thing is that the mantle cell lymphoma is included in the WHO classification as the distinct lymphoma subtype. So it is characterized by it is already characteristic by the translocation 11:14, which is already given in the question, with the Q13 and Q32 translocation, which results in overexpression of cyclin D1. Okay, and the clinical presentation often include the extranodal involvement, particularly of the bone marrow and the gut. So here the gut involvement was already there, and the prognosis of the patient of the mantle cell lymphoma, then median overall survival is 3 to 5 years, and poorest among the B cell lymphoma patient. And the classic appearance of the MCL is like uh, monomorphic proliferation of small to medium sized lymphoid cells of the irregular nuclear contours and the inconspicuous nuclei, and around 4 cytological variants of MCL can be recognized, including the small cell variant, marginal zone like variant, blastoid variant, and the pleomorphic variant. These are the different types of variant which can be classified. The blastoid and the pleomorphic variants are considered to be associated with a very poor prognosis, and the majority of MCL cases express CD20, which was given, CD5, BCL2, cyclin D1, and usually it is negative for CD10, BCL16, and CD23. I think CD10 was already given in the question as, if I am confusing, CD23 is negative, and CD Now here in the mantle cell leukemia, it is very much that I was actually seeing. It is very much coinciding with the chronic lymphocytic leukemia also, because but the one there is a great difference between that. The in the MCL actually the CD23 is always positive, whereas CD23 is negative in the case of mantle cell lymphoma. Uh, so. So the answer, it will be the mantle cell lymphoma, and it should not be, neither it will be a marginal zone lymphoma or follicular lymphoma, because they are not coming in the purview of the question, because the translocation easily it is recognizable as mantle cell lymphoma. So the answer will be like this, and the main thing is that it actually microscopic gastrointestinal tract involvement may be seen as the 90% of the presentation, and routine, but the routine colonoscopy and endoscopy is not done here, and the treatment are not clear cut, and though we can give R-CHOP regimen, which is widely used, or R hyper CVAD regimen is also preferred as a first line of treatment. And now fit patients with a complete response should consider for autologous stem cell transplant, and relapsed patients should be taken up for the reduced intensity conditioning allogeneic stem cell transplant. These are the some of the treatment regimen, like R-CHOP is used, CVAD also, R hypersensitive CVAD is also used, and but the prognosis is not so good in the case of the non-Hodgkin's mantle cell lymphoma. Now a patient has this is also one of the important question, uh, that is what should be the treatment of choice, the TOC, for the splenic marginal zone lymphoma. The patient like has a diagnosis already of splenic marginal zone lymphoma and has been presented to you in hematology clinic. So what should be the treatment option which you should offer to him? Now, this is also the case of a non-Hodgkin's question only. Uh, so, I have asked the question about the treatment of choice for splenic marginal zone lymphoma. So, what should be the treatment of choice for splenic marginal zone lymphoma? Whether you should consider for splenectomy, or whether you should start with giving R-CHOP regimen, or whether you can think for giving radiotherapy, whether you can keep for rituximab, etc. So, as per me, the treatment for the splenic marginal zone lymphoma is the best should be to give rituximab, and the splenic marginal because as a detail, splenic marginal zone lymphoma is a very uncommon indolent B cell lymphoma. Okay, that you should remember first, and causing marked splenic enlargement with CD20 rich lymphoid cells infiltrating the blood and bone marrow, and the splenic marginal zone lymphoma, that is SMZL, expresses the B cell antigens like CD19, 20, 22, and typically CD5 it is negative and CD10 is also negative. CD43 is negative, CD183 negative, and CD25 negative. And the lack of CD25 distinguishes this CD5 actually the distinguishes SMZL from the chronic lymphocytic leukemia and the mantle cell lymphoma also. And the lack of CD103 and CD25, that you must remember, because CD103 and CD25 it distinguishes SMZL from the hairy cell leukemia, because there the CD103 and CD25 is actually positive there, but here the CD103 and 25 are not not in purview, and it is negative. So, because splenic marginal zone lymphoma may often follow an indolent course, and overall 5-year survival is 80%, and asymptomatic can be followed with a conservative wait and watch and wait approach. And in these patients requiring the treatment, there are several several different approaches, including the single agent rituximab. So, and splenectomy and traditional chemotherapy in pre-rituximab earlier, the treatment of choice of the patients was symptomatic for the only for the symptomatic splenomegaly or threatening cytopenia. Since chemotherapy had limited efficacy at that time, now responses to splenectomy occurred to approximately 90% of the patient. Now in rituximab era, and the treatment regime is very good. 90% of patients are fully cured. And in the case of the rituximab era, splenectomy should no longer be considered as initial therapy, that we should always remember as in the SMZL, but rather as a palliative therapy for the patient not responsive to immunotherapy or without chemotherapy. So rituximab is a very effective and well tolerated therapy that we must know, and it may be substituted for splenectomy as a first line treatment choice for the patient with SMZL and SMZL, that is splenic marginal zone lymphoma, and patient should be given weekly rituximab 4 to 6 weeks, followed by maintenance rituximab every 2 months for at least 2 to 2 to 3 years. So this is the actually the treatment of choice for the case of the splenic marginal zone lymphoma. Now, just I am concluding this with a very small video, because today is my first video for the postdoctoral, those who are doing PDT in clinical hematology, and I will give in the next video I will post some of the most discuss with more important malignant and non-malignant condition in the hematology, and I will discuss. And if you have any doubt, you can always ask me in my in the YouTube channel also, because I am you know my name as Dr. Raja Bandyopadhyay, and there also you can write, or you can in the Facebook also I am active as Raja Bandyopadhyay. You can message me there also. If you have any doubt regarding in hematology in any chapter, you can ask me. And in the next video I will be discussing some more questions on malignant as well as non-malignant chapters on hematology. And so till then, just I am concluding, because I have given very short, only brief questions. And actually, though these questions are actually multiple choice, but actually I have this prepared these questions as a multiple choice, because by multiple choice question only you can get you can just make a broad sense of a bigger questions. So just I have started just now, and as I will be following the seeing the more university questions paper, I will be giving you the long answer question, and I will be discussing it here in my video only. So till then, you take care, and all the best.